Time to get started. I'm going to go ahead and share my screen. It looks like we are recording. Outstanding. Hopefully that looks all right. Well, welcome to this final day of February 2025. We certainly will have some folks joining as the session goes on. But our usual format here will be to go through some opening notes and reminders. If this is your first time with us, if you want to put your contact information into the chat, that would be great. And then we have the excellent fortune of having Dr. Sue McCurry presenting on an enhanced perspective for understanding and responding to inappropriate behaviors or behaviors that are sometimes the most skillful expression of unmet needs. We don't have a formal case, but we have plenty to talk about and a lot of clinically relevant discussion, I am sure. So some reminders, if you are able to, having your video on is great. We've mostly mastered the art of muting. We don't always master the art of unmuting before we talk, but we'll work on that. And if there are more than one of you in your location, if you could put everyone's name in the chat, that would be great. Just helps with attendance and CE issues. Speaking of which, if you are a University of Washington affiliate, either faculty, staff, or student, here is the process for claiming CE. Just texting that number. About an hour on either side of the event to do so. If you are not, and we'll put that up at the end of the session as well. If you're not, we'll just keep track of your attendance via the usual mechanisms, and I thank Sammy for her work on that. Just some reminders about other learning opportunities. Our sister program, in a way, the UW Echo Geriatrics, which occurs interstitially with our sessions on the third Friday. The TBI, Psychiatry and Addictions, Telebehavioral Health Series, so lots of great stuff. In addition to some phone consultation options and other conference series, and a repository of prior sessions through our Grand Round series, both for neurology and psychiatry, many of which are dementia relevant, geriatrics relevant. Also, a reminder that next Friday is the Dementia Innovation Summit, and this is a primary care focused event put on by the Dementia Action Collaborative. I think we've got about 95 people registered at this point, including some folks from Montana and other parts of the WWAMI region. So it proves to be an excellent event. And we will have a bonus echo session from, I think, 12:15 to 1:15 with our own Sylvia Russo presenting the didactic and then a little mini case. So just to put that on your radar. We'll also put the Healthy Aging Summit put on by Providence Swedish on Friday, April 18th, another mostly full day event. There's the QR code for that. We'll also send this information out after our session today. We, as I mentioned, do not have a formal case today, but boy, we always get so much out of case presentations, given that this is at least a good chunk of our learnings are case-based. And providers get a very thorough document with suggestions, resources, and recommendations. So benefits to everyone. No case is too simple, or some people in the waiting room here in. There we go. All right. And then also in our discussions, making sure that we are protecting PHI. We can always go back and edit things out, but better to be proactive about that. And of course, all of our sessions are indeed online and recorded for your viewing pleasure. And we will certainly value your input in terms of our 1-minute post-session survey. It's been critical, that information has been critical to help us iterate and reiterate this program to make it optimally useful for you all. We're accredited for CME. We don't have any disclosures today that are relevant. And every time there is one, there is a mitigation process here at the University of Washington. Here is our hub team. If you've been with us for the last few years, you know us well. And then here are all of you out in the community around Washington State and some outlying areas that serve patients and families from Washington. At this point, we are kind of well into it, but actively recruiting additional folks, particularly from FQHCs and rural clinics. That will be our increased emphasis for this next year or two, probably beyond that. So if you have colleagues who would benefit, we try to make the lift relatively light and the barriers fairly low to joining and participating. All right, so I am going to stop there, and it is my absolute pleasure to introduce Dr. Susan McCurry, who will be doing our didactic today. And I have had the good fortune of having known her for a while now, and we share a lot of colleagues in common, and Dr. McCurry published what I would consider to be some of the seminal work around insomnia and sleep in dementia, as well as a number of papers on non-pharmacological interventions around behaviors. She was an assistant professor in the Department of Psychiatry before becoming research faculty in the School of Nursing, and has been emeritus in that department since 2021. She also maintains a small but robust and very active private practice, typically working with older adults and family members who are dealing with mild cognitive impairment and dementia, and she remains at the top of our referral list. So a valued colleague and a wonderful resource, and boy, we're fortunate to have you present to us today, Dr. McCurry. Thank you.
You're welcome. Thank you very much, Chris, for that introduction. That's lovely. Let me share my screen here. And get to the slideshow. Hopefully everyone can see my slides.
That looks great.
Great. Oops. Oh. Okay. Oh dear. Let me exit out here for just a second. Oh. It always goes so smoothly when you do the practice. All right. Get myself organized here. All righty. So again, thank you very much for inviting me here. I'm really pleased to join you today. When I got the invitation from the ECHO team, I was asked to talk about managing dementia-related inappropriate behaviors. That was the email. And when I looked back over previous ECHO presentations, I saw that you've had variants of this topic presented to the group on multiple occasions by excellent speakers in the past. And I didn't want to just duplicate what it looked like they had already said to you. So I'm going to try to explore these behaviors today through a slightly different lens that might provide us with additional ways or new ways of understanding these behaviors and of intervening with them and of talking to care partners. So before I start, I want to acknowledge that some of what I'll be presenting today is derived from book and video materials that I've published and presented in the past. And I noted earlier to Chris that my 2024 tax records show that I received zero income from any of these last year. And these are the learning objectives associated with my presentation. I'm going to be using the currently preferred term neurocognitive disorders and then the more familiar older term dementia pretty much interchangeably throughout this presentation. And I'm also not going to be distinguishing between mild and major neurocognitive disorders, since the conversational points that I'll be making throughout the talk are relevant across the cognitive continuum. So this slide just shows some broad categories of emotional and behavioral changes that people with neurocognitive disorders can develop. And obviously the list is not all inclusive. And I've also not organized it using typical neuro cognitive testing terms like complex attention or executive dysfunction. I've rather tried to generate a list that summarizes common, observable, and covert behaviors that care partners and people with dementia themselves describe to us. And I want to start with the hypothesis that none of the behaviors on that previous slide are inappropriate per se. All behavior has meaning and purpose. And this is as true for people with neurocognitive disorders as it is for you and I. Of course, sometimes people with dementia do act in ways that we might call inappropriate because the behaviors outside socially preferred behavioral standards for that situation. But using that definition, of course, particularly in the days we find ourselves, it's pretty easy to find examples of people with no known neurocognitive disorders who are acting inappropriately in the service of getting something they want. So my point is, these behaviors are not unique to dementia. That said, it's true, as everybody on this meeting knows, neurocognitive disorders are brain diseases, and that can impact information that is received, sensations, memories, response tendencies of the affected individual, and can lead them to behave in maybe uncharacteristic or maybe exaggerated versions of how they would have acted in the past. But what's interesting to me is that neurocognitive disorders affect each person differently, right? And that's in part due to the nature and the location of the brain disease. But these individual differences are also influenced by each person's lifetime of experiences, right? Their learned habitual responses, their personalities, their past successes and their traumas. And so we as clinicians really need to approach every case we see with great curiosity. You know, what is it? What are the unique historical or environmental or psychosocial circumstances that are leading to the particular mood or behavior change that you might be seeing in the person in front of you or not, regardless of what the typical neuropsychiatric trajectory for this diagnosis might be. And what I particularly want us to consider here in our time together is how these symptoms, when they do emerge, can be seen as attempts by the individual to communicate with us and to maintain social connections with the people around him or her, and that is including with you and me, the clinician. So I emphasize to care partners that I see that emotional and behavioral changes that emerge with cognitive decline are not childish, and the person should not be treated as such. You know, all humans, including care partners and clinicians, perform less under stressful circumstances, right? We tend to fall back on familiar and long-standing defensive or self-protective responses when we feel threatened. This notion that under stress, we all regress. So let's consider the possibility that emotional and behavioral changes in dementia are actually a normal reaction to cognitive decline. So for example, if you didn't recall you were in a physician's office, how would you respond if someone handed you one of those blue roby things and told you to take your clothes off now? Or how would you respond if your son had brought you to this doctor and wanted to have your memory tested to see if you could continue living in your own home or keep driving? You know, what would your response possibly be? So psychologists like myself and behavior analysts use something called functional analysis, or the ABCs of behavior change, to help understand and intervene with these changes that occur in dementia. So if you think of it this way, most things that we do in life are chains with multiple links in them. Each link is connected to the next. And from a behavioral perspective, we might say an action is followed by a consequence, and that consequence becomes an antecedent that leads to the next action and so forth. So a good example is an ATM machine, right? Each step that you take cues up the next step, and the screen instructions change accordingly. This is a basic process that underlies virtually everything we do, all of our activities of daily living, taking a shower, taking out the garbage, getting dressed, as well as more complex social interactions and rule following. But what happens if the ATM's display is frozen? No next step appears. This actually happened to me recently. You know, it's a Sunday afternoon and my card's stuck in the machine and the screen is frozen. And I don't know what to do. I'm like paralyzed. You know, have you ever walked into the kitchen and you can't remember what you went there for? So you probably went back to the room where you'd been previously and you remember what it is you were going to the kitchen for. You go back in the kitchen, problem solved. But imagine that these kinds of broken links, these freezing up, these gaps, are happening every day. And that if you try to retrace your steps or you try to find that piece of paper where you've got all the passwords written down, it just leads to more gaps and more frustration. People with neurocognitive disorders pull these kinds of blanks all the time. And they lose their train of thought and just wander off in another direction. So the appointment gets missed, or the bill doesn't get paid, or they don't remember to say thank you ever to the care partner who's helping them so much. You know, for a lot of people with neurocognitive disorders, this is the very first sign, the earliest sign that something is wrong, are these breaks, these gaps, these missing links. But of course, in real life, the ABCs are much more complex. They're like a web. These activators and consequences are linked together in very complicated ways, and there are lots of places where links can get broken. And so there's like unlimited possibilities in behavioral responses or irregularities that a person may exhibit as they try to compensate for these broken links. So, you know, in the beginning, family members are often, when they start noticing them, are going to attribute these lapses to the person not trying hard enough or not paying attention. And again, imagine this is happening to you. So people might start to make comments, or they may be kind of jokey about it, or they may scold you, or they may say you're being stubborn, or they may get like sad expressions on their face and start doing things for you because you don't do them fast enough or you don't do them right. How are you going to respond in this situation? You know, you might become defensive and angry, or you might become flustered. You're trying to explain yourself, or you might withdraw because you're embarrassed, or you might just deny that what they're saying is even true. But can you see that all of these responses are these troublesome, inappropriate behaviors are a normal human response to a very confusing and stressful situation, right? The person with cognitive decline is communicating something to us. They're experiencing something and they're trying to protect their sense of self-worth and independence. Remember, under stress, we all regress. And it's not surprising if people with cognitive decline can become rigid or petulant or unreasonable. And of course, this whole situation is very stressful also for the care partners who may fall back on their own historical rigid patterns, their self-protective defenses. You know, in these very strange situations, it's easy to forget that cognitive and functional decline can be made temporarily worse if a person is physically or mentally fatigued, or if they're feeling pressured or afraid, or if they're hungry or constipated. People with vision and hearing loss are going to be more likely to become withdrawn or suspicious. It's been suggested that maybe up to a third of people who are living in the community with neurocognitive disorders have some sort of underlying medical condition like pain that needs addressing. So we, of course, as clinicians are aware that we need to always be open to the possibility there might be some underlying medical problem or condition that's contributing to the behaviors that we're seeing. However, the thing is, we need to teach care partners to think about this as well. They're the ones living with this person. And we need to teach them to start to observe, looking for patterns and clues for why is this behavior happening to this person at this particular point in time. A lot of care partners that I talk to really don't understand the way that underlying medical conditions or medications or sensory loss can affect mood and behavior in people with cognitive impairment. So we need to teach them this principle and also teach them to always connect with you, the providers, if there are any sudden changes in mood and behavior. I want to go back to the communicative function of emotional behavior changes in folks with cognitive decline. So when we observe clients and collect our assessment data, our methods are primarily relying upon language, right? We talk to our clients. We ask people to fill out questionnaires. We gather histories and we read medical records and they tell us their stories. Of course, for people with dementia, the verbal history may be factually inaccurate or unreliable. You might think that or imagine that this intersection between the two circles starts to shrink as the neurocognitive disorder progresses, right? The correspondence between what people say they did and what they actually did, or what they say they're going to do and what they actually do can break down. Now, people without neurocognitive disorders, it's not unusual for them to just blatantly lie to achieve their own ends. Our folks aren't doing that, but this breakdown of congruence, verbal congruence, easily becomes a problem. So, for example, imagine that you're a pilot and a co-pilot flying a plane together. You and the patient are like flying through daily life, and you're reading instruments and checking with one another to see if there are particular things in your environment that needs responding to a certain way. But what if your co-pilot has lost his or her ability to read the instruments? Or what if sometimes the ability to read the instruments is perfectly fine and it's completely off at other times? And what if you can't reliably tell the difference? Even very experienced clinicians can be lulled into overestimating someone's cognitive capacity if they have very good verbal social skills. A metaphor I often use with care partners is that of electrical wiring problems in your bathroom, which is another situation which I've actually encountered. Sometimes the light is on and sometimes it's off and sometimes it's flickering, and you can never predict when is going to be which of these instances. But in this situation that we're talking about, you can't even actually see whether the light is on or off. And so this is super confusing for family members, right? Who they don't understand this inconsistency in cognitive and functional status in someone who looks the same day after day, but isn't performing the same. So imagine a daughter goes and she picks up her mom at an assisted living facility to take her to a doctor appointment. And mom's supposed to be ready to go, but she can't find her wallet that has the insurance card in it. So the daughter keeps asking mom, well, where'd you put your wallet then? Where did you have it last? And eventually mom says a cleaning lady came into the apartment and took it. So you see how the person with cognitive impairment, despite everything, is trying to communicate and connect, right? I would probably suggest to this daughter that mom's not paranoid or hallucinating, but she's actually offering a pretty plausible explanation for the missing wallet. I mean, imagine if you honestly don't recall where you last had your wallet. Is it possible you might say, well, maybe somebody stole it? So this reason giving that is a verbal behavior that's shaped up very young in children, and it's maintained well, into the progressive disease process. And offering a reason or an explanation can help someone save face, or it can help them escape an uncomfortable situation, even if the explanation that they're giving doesn't really make sense to the observers. And to further complicate matters, dementia can impact this correspondence between how a person says they feel and how they actually feel. So a person with dementia may have a broken leg and be kind of wincing in pain, but if the EMT asks, "Are you in pain?" they'll say no. My colleague and friend Claudia Drossel actually witnessed this once. She was a pre-doctoral intern at a VA, and she's in the hospital room with a patient who had been released from surgery recently, and he's hunched over and he's holding his head and he's moaning and grimacing, and the medical resident comes in and says, "Are you in pain?" And the patient says no, and the resident says, "Well, then why are you holding your head like that?" And the patient says, "It just seems like the thing to do." So, our medical system relies upon reliable self-report. And when this breaks down, it can cause a lot of problems for us as clinicians and for family members who are trying to assess the need for intervention and how to respond when someone has underlying problems that are causing their symptoms. Care partners also express to me a lot of frustration with their family members who just won't accept explanations or rational discussions. And I try to help them understand that some people with neurocognitive disorders honestly are genuinely unaware of the difficulties that they're having. And that this is another symptom of their disease, like other neuropsychiatric symptoms. And our very, most diligent best efforts to try to convince them to, move to assisted living or stop driving or wear incontinence garments may be met with great resistance. And this isn't the same thing as denial or stubbornness. If you honestly don't believe there's anything wrong with you, then why are you going to agree to things that impact your sense of identity and autonomy and independence? So, given all this, how do we build a support or what we might call scaffolding to help hold people with cognitive impairment and their care partners together? And one place I would recommend you start is to always spend time talking with each individual separately as well as together. If this is a dyad, if there's more family members, try to get individual time with them and time together so that you can observe and come to understand their differences in perspective. Because if our scaffolding and our support systems that we try to put into place can take into account everybody's understanding about what's going on and preferences and needs, it's more likely to be successful. And we're less likely to have those sort of big, uncharacteristic behavioral responses or catastrophic reactions develop. I also talk to care partners about looking at things from like a 30,000-foot view here. If the person is too caught up, the caregiver is too caught up into the weeds, and I know I mix up all my metaphors all these times. They're too caught up in the details of the moment. They can't see the big picture. It's harder to decide, how do I proceed and how do I move forward? So we want them to try to take a big view so that they can look for these patterns and the context in which particular problems are developing. There are, of course, many excellent books and resources that are out there. Echo has listed a bunch of them for you when Chris was opening up this presentation here, that offer specific strategies and suggestions for dealing with behavior and mood changes in cognitively impaired individuals. But one of my favorite resources in recent years actually isn't a dementia book at all. It was originally written for family members and providers who are treating persons with severe mental illness. I've found it's also very useful for care partners of persons with neurocognitive disorders when the dyad is in disagreement about what's happening or needs to change. What the acronym LEAP, teaching the caregivers to do reflective listening, to empathize with the feelings persons expressing, and to find some place of agreement, some point where you can both agree and try to partner and build from there in developing problem-solving strategies. So this LEAP approach is similar to a communication tool that was developed by Linda Terry a number of years ago here at University of Washington. Listen with respect, comfort, redirect. And both LEAP and Listen with Respect have this respectful, empathetic listening at their heart. But my experience has been that for some persons with neurocognitive disorders, particularly when they're in the earlier stages of disease, providing comfort and redirection or distraction can be ineffective or even backfire if the person feels dismissed or talked down to. So for these persons, finding that common ground that you can both agree on and then developing a plan and partnership going forward can be helpful. I also emphasize to care partners that dementia care is a ultra marathon. It's not a sprint. And in this case, you don't have a map of the route and you don't know how long it's going to take. So it's super important to stay as hydrated and refreshed as possible along the way. Respite breaks are essential for care partners. They already know that this path isn't going to be easy, but they need to understand that there are people along the way who can help them. And they don't want to be running alone, that community and respite are essential for being part of that long-term caregiving role. I'm going to close by returning to our first consideration, which is, what if neuropsychiatric symptoms are normal reactions to cognitive decline? Normal human responses to a stressful situation, and attempt to communicate, and attempt to maintain social connections when they seem to be breaking down. Dr. Janelle Taylor, she's medical anthropologist at University of Toronto now. She used to be at University of Washington, and she talks a lot about this desire for connection in people with cognitive decline. Many people think that individuals with dementia, what they do or say is irrational. They don't recognize you, they repeat themselves, they sometimes talk seemingly nonsense. And as a result, friends and family often walk away. They stop coming around, stop calling. I think this is the real tragedy of dementia, is our response to it, right? These individuals, and sometimes I think we as clinicians forget that this shared congruence of verbal content, agreement, is not all that underlies communication in dementia. There's also procedural communication, that we continue to communicate with people with dementia with body language, with tone of voice, with facial expressions, and we can do that very effectively well into the disease course, maybe to the very end. I remember years ago, Steve Albert saying to me that the one thing people with dementia retain, no matter how advanced their disease, is the ability to know what and who they like. I've often heard people say, she's not there anymore. They don't see the family member or the friend or the person they've known anymore. They only see their disease and their symptoms, their memory loss. she's not there anymore. And I have to tell you, every time I hear this, it breaks my heart, really. So my closing consideration for you is that mom is still there. I am always trying to help my clients, and this is both care partners and the individual with dementia themselves, to understand that their rich history and personhood that has brought them to this moment is not diminished by the fact that they now have a neurocognitive disorder. So the work that we do with persons with dementia and care partners is one of hope, right? We're focused on there's life to be lived, not on the diagnosis. And none of us have a crystal ball that's going to be able to tell our clients what their particular disease progression course is going to look like. But we do know that if we can come to understand any changes in cognition and mood and behavior that occur as potentially being normal responses to a confusing, stressful situation, as being attempts to communicate, as being a longing to stay connected, including with you, the clinician, then we're going to be able to help them more. Their course is going to be better. If we can hold on to that belief that mom is still there, there's always problems that arise in life, and like in this chess metaphor, and having a neurocognitive disorder is no exception to that. But we can still help our clients keep playing the best game that they can, given what they've got. So just as my last slide, I just want to acknowledge some of the colleagues who have made this presentation possible. And I thank you very much for listening.
Oh, thank you very much for all of the outstanding information. And boy, we've got lots of opportunity to dive a little deeper into some things. And maybe let's open it up for questions or comments. I have a couple, but I'll hold off for a bit. All right, maybe I'll ask it since we'll give people time to formulate their own questions. So one of the things that comes up frequently, and I'm curious to get your perspective on this, you got me thinking about it about 5 or 6 slides back, is the idea of, kind of the gentle deception or therapeutic fibbing that sometimes helps decrease distress or agitation. I'm not sure your perspective on that, or kind of what you tell family members.
Well, the first thing I typically inquire with family members is how do they view that strategy themselves? Some family members actually find it pretty morally, ethically unacceptable. And in cases like that, then rather than taking a therapeutic fib like, well, where's dad? And you don't want to tell them that dad died 10 years ago. So you say, dad will be coming by later. They can instead work with truth, but in a way that is more redirectional. So tell me about dad. Sounds like you're really looking, you love dad very much. What is it that was your favorite thing about him? I've got this picture of dad, it makes me remember and think of the times when you were together, just trying to intervene in a way that doesn't require lying. Other people understand more easily, I think, that truth is fluid when it comes to people with a severe cognitive disorder, and that maintaining the relationship is what's most important. I like to tell people, do you want to be right or do you want to be in a relationship? And not pushing reality or truth on someone is sometimes extremely helpful, obviously, because it eliminates upset and distress, which is going to make cognitive functioning worse. So,
Oh boy, there's that piece too of validating the emotion, you know, of where's dad, and like, oh, you know, must be really hard not to know where he is, or, you know, acknowledging kind of
Mhm.
that and then redirecting. It's a nice approach. Um, other questions from our
Yeah,
community?
I guess the one thing I will say about the acknowledging the feeling is I don't know how many of you have seen this series of videotapes that Linda Terry did over the years, but she has one where she has a care worker who comes into an assisted living or a memory care room, and the patient is sitting there looking very sad. And he asks her, "How are you feeling today?" She says, "I'm feeling really sad." And, you know, he's very sympathetic. And she says, "My daughter never comes." And he says, "Yeah, I've noticed that. It's like, it's really hard when your daughter never comes." And it's an interesting vignette because the care partner is presented as someone who's trying to really allow the person with cognitive decline to have their feelings and not, you know, undermine them, not take away their right to be sad, and acknowledging them. But uh, by delving into, yeah, I can understand you're really sad, it actually makes her sadder. You know, she has an exaggerated response to that. So um, you want to acknowledge the feeling, but it can be tricky. You can help slip the person deeper into what they're upset about if you do it the wrong way.
Craig.
Thank you. Great talk. I like what you said about mom is still there. I think that's very powerful. Thank you. I, well, a friend of mine, his mom lives with him, and the mom has like 5 kids, and she would go around and live with each kids. And finally, now she's so weak, she decided to live with him. So recently she said that, oh, there's somebody in the room. And my friend said, there's nobody there. And then it keeps happening. So finally he said, there's nobody there. If you think there's somebody there, uh maybe you should move to another sibling, and live with another sibling. So she has to be quiet because she's afraid that she doesn't want to live with other siblings. She only wants to live with him. So I try to talk to him about, kind of ask what she's seeing, instead of saying like there's nobody there. And then and that but basically my friend said it worked. She's afraid, so she doesn't want to talk about it. So I don't know, what do you think, how should that be handled? I was just thinking, maybe she's still seeing it, but she's not maybe if we don't talk about it, maybe she's gonna get afraid and she's gonna get agitated. So what do you think?
So I have a lot of thoughts about that. One thought is it would be interesting to know when she sees things. Is it at a time of day when the light's getting dimmer? Is it when she's looking outside a window, a particular window? So one possibility is she's seeing something that's actually there, but her brain's misinterpreting what it is. So that's just information gathering, I guess. I would be interested in, is she upset by what she's seeing? Sometimes people are seeing things, or their brain is making sense of what they're seeing and interpreting it however they do, but it's not distressing in any way. And so inquiring, well, what are you seeing? And does it bother you? And, is it okay? Sometimes people are quite happy to be seeing the things that they're seeing. So sort of the emotional response of the person would be important. If there's some evidence that perhaps this is a misperception, that a coat hanger is being interpreted at night when she gets up to go to the bathroom as a stranger standing in the hallway, that there are environmental modifications that can be made that will reduce the likelihood of that misperception occurring. I agree with you. I think perhaps you can get mom, for a time anyway, to not comment on what she says because she's afraid it upsets the family and she'll be made to leave. But I wouldn't recommend that as a strategy for family members.
Yeah, I try to ask. So it usually she sees that the person at night. Um, I can't tell if they didn't tell me what I did ask about, is she upset? If if she's not upset, then just kind of ask more about it. What do you see? But they really brush it. They said it worked. So
Mhm.
now she's not talking about it
Mhm.
anymore. So we'll see.
Mhm.
Yeah, yeah.
I remember a number of years ago, I heard someone on NPR was talking. It was a man and woman, and they were both what's that comedy that you do? Spontaneous. I'm having a word retrieval problem on my own. What's the word I'm looking for here? Somebody, improv.
Improv.
Thank you. Yeah, they were both improv actors, and the wife's mother developed dementia and came to live with them. And she was prone towards visual misperception. She would see a lot of things outside the home. And the husband discovered that if he just responded to whatever she said as if it was fine and just asked her questions about it and talked about it, that it was very good for their relationship. She didn't get upset. And the daughter had a harder time doing that because she was closer in history to her mom. And she couldn't quite take that improv hat on and respond to mom's misperceptions in the same way. But I think that's an example of how kind of going with it can sometimes be extremely useful.
Thank you.
Thank you.
Yeah.
And Reza.
Thank you for the talk. That was interesting. Very, very good. The question is that this behavior changes. Does it bother the patient or bothers the family or caregivers? I think that's the main question. If it bothers the patient, I mean, my approach is that, for example, I have a patient a few days ago. He talked to me that I'm going to a relationship. It was not true. He's at 18, 19 years old. But the description that she gave me was description of her husband, basically. So, and I was saying, are you happy with this relationship? Yeah, I'm happy with that. So let it be happy then. So if it's not scary, if the patient doesn't tell me that, oh, I saw someone who is going to, rob my money or came to my room without my permission, I interfere. I try to give them some antipsychotics, sometimes look at for example, as you said, environmental factors. For example, I had a patient, she was hearing the kids singing for her in a specific place. And that was her room. So we changed, I asked the family members to change the room and the kids are gone. So those type of things that can help, we can intervene. But sometimes it bothers me or bothers the family members. For example, my mom tells me a story 5 times a day. And I just all the time say, yeah, that's right. Good. I don't even tell them that you told me about this story, for example, a few times. So most of the time is the caregiver who got bothered by asking this question. The other strategy I have, I use writing a lot. I have a marker in my office. Anybody comes and I said, for example, every Tuesday you take free. I actually asked them to sign a contract with me that every Tuesday, for example, you get shower. I sign, they sign, and I show the pictures to them, and then I tell the family members that don't worry, every day could be Tuesday. If it's Wednesday, you want to take a shower, just show it to the patient. He doesn't remember that, and it's for his health. It's for his health, and there's no logic. There is no way that you can prove that today is Tuesday or Wednesday. I say it's Tuesday, you say it's Wednesday. So mainly those type of things. Writing, I think, is a very good strategy. I have, again, marker in my office. I learned it from my attending physician in Beaumont Hospital,
Mhm.
Dr. Allen. She always wrote on the papers, large letters, put in the patient, give the patient, and it's very helpful. So that's my suggestion. But thank you so much. Great lecture.
Those are all nice examples. It reminds me, I recently saw a couple who the wife was the one that was developing the cognitive decline. They were in their 80s and had been very high functioning individuals in the past. And the husband was extremely distressed by his wife's symptoms. And one of the things that was upsetting to him was issues around cooking meals and dinner time. And I did something similar in that I had them together. We developed a plan for how to deal with this conflict over dinner. He would say to her in the morning, "What are we going to have for dinner?" They'd open up the refrigerator. They decide we're going to have, ground beef. We're going to have hamburgers, and she always did the cooking, but then she wouldn't take out the meat, so it would still be frozen when dinner time came. Anyway, it was sort of, he had expectations for her to continue acting a certain way. So we developed this written contract together about how he would respond, and that he wouldn't nag her, and took it home. And they came back the following week, and they basically had never used the contract, and everything was moving along almost swimmingly now. And it wasn't because of the contract, but it was because in the process of developing that together, it had helped the husband come to the realization that his wife was no longer going to be able to running the kitchen and the dinner meals the way she had done it for all of their lifetime. So the document was a reminder to him of what he had learned in the process of talking about it. Yeah. I mean, ultimately, it's the caregivers who have to change, right? The person with cognitive impairment is not going to likely change. So caregivers have to come to understand that I used to talk about it's like a dance. You're dancing, and the person with dementia is leading. The care partner is not, and we have to be able to kind of follow them around and still maintain our quality of life and the quality of life for the person maximally together as best you can.
Makes me wonder what you tell people, and I'm sure it's case by case and person by person, but I think about the couple things. One is that, 40 or 50 years worth of roles and routines, and then that all changes, right? And how to navigate that, and then how to, help people get their head around quizzing and correcting, and maybe removing some triggering words from their vocabulary. I mean, these are such hard things to do sometimes.
When I'm in my practice with people, I try to use humor a lot. I find if you can get both the person with cognitive decline and the care partner laughing, so one of the things I say to care partners, I say there are 3 rules of dementia care. And the first rule is don't argue. The second rule is don't argue. And the third rule is don't argue. Unless it's a matter of personal of safety, unless this is a safety issue, to the extent that you can just completely eliminate from your interactions challenging, arguing. Now, of course, if you've been married to someone for 55 years, that seems impossible because you have your own pattern of working things out that you've developed. It's well established. So it's hard, but they'll generally laugh when I say that, but they remember that, and it's a matter of starting to practice dropping those criticisms, those insisting that people do things a certain way. You're trying to let that go. But it's just practice. And I tell them we're not in heaven yet. This This is a process. This is a journey, not an arrival. You're not going to wake up one day and now you're doing this perfectly right. You're handling everything just right. It just doesn't work that way. It's a practice.
I'm going to, I'll give you credit when I use it, but do you want to be right or do you want to be in a relationship? I'm taking that one. So like that. Kelly.
Sorry, thank you so much for this talk. It was so interesting. I think it really gives us those skills to take to patients and their caregivers. I just had a question because there's a little conflict for me. Like, yes, improv with patients and some of their delusions, if you can kind of work them through them, but then also you're like, well, don't lie to them. And sometimes I'm like, well, isn't it easier sometimes to kind of, you know, lie in an essence, or for your example, like, oh, dad passed away 10 years ago, you certainly don't want to bring that up, but is it really harmful to say, oh, yeah, he'll be around soon, I'm sure he'll be here for dinner or something? Is that morally just not the right thing to do, or?
Well, for some people it is. That's the thing. You have to understand the stance that the care partner is coming from. Some people feel very strongly that to say something that is at all an untruth to their care their care receiver is just a very bad thing. And so I'm not going to tell people, go ahead and do that anyway. Now, things like visual misperceptions are interesting because, you know, I tell partners, as I'm sure you all do, someone who is seeing things, their brain is seeing what it's seeing. They're not just saying they're seeing this to be irritating or upsetting. You know, for them, what they are seeing or hearing is real. So it's not a matter of lying to them if you go with it and you ask them to describe it and how does it make you feel, and oh, that's interesting, and talking about it. Care partners are afraid if I do that, then what's going to happen is they're going to do more of it, that they're going to lose touch with reality. And I tell them, it's just my opinion, that's not the case. That they are seeing and experiencing what they're seeing and experiencing, and asking them about it, and interacting with them in a way that makes them feel like it's like that leap thing, that you're reflecting back what you hear them saying, you are empathizing what they're experiencing with, that's not lying, even though what we're seeing or hearing is not what they are. But what they're seeing and hearing is real to them. So it's not a lie to engage with them about it.
Like, I have one patient who gets agitated for hours, no medications are helping. Like, what other things should I be telling the partner? I know that's a really general, huge topic, but like,
well, sometimes medications don't help.
Mm-hmm.
You know, I saw someone for several years off and on who had Parkinson's disease for a very long time and developed what we would think of as a severe psychotic paranoid disorder. And she's been in inpatient treatment. She's been, and her symptom relief has been pretty minimal with everything that we've done environmentally and medication-wise in treating her. She is a very frightened and unhappy person. That said, remember I talked earlier about, part of the story when people develop any kind of neuropsychiatric symptoms, I believe, is their history. And she came from a traumatic history. And she came from what she had described to me over many years, an extremely difficult marriage. That she had reasons for a long time to be suspicious and frightened. And so our medications can't take away that history, right? when she was able to be in an outpatient setting and I would see her, she had moments where she had recognition that some of what she was believing was not true. But as you know, they'd had a lot of difficulty managing her Parkinsonian medications. And she'd been a complex medical treatment care patient from the beginning of with a disease she'd had now for a very long time. So sometimes our best won't take this away. That said, we still can connect and can relate. And, you know, when I can see her, I can still reach her with our own history of relationship. And, you know, I can't take away her symptoms, but I can connect with her as a person. And sometimes that's the best you can do.
Well said. Karen?
Hi, everybody. I'm Karen. I'm the Echo Dementia caregiver representative and have a question for Dr. McCurry, which I totally agree. The caregiver's response, reaction, perception, interpretation of the behaviors is crucial. And it amazes me how little training paid formal caregivers get in behavior understanding and management. And I'm continually distressed about how little in-home family, quote, informal, unpaid caregivers get. It's kind of like if they don't seek it, it's not going to happen. And so I'd really encourage all the care providers on the call to really reach out to the caregivers and offer some resources. I took several, through the 8 years of caring for my husband, several courses that helped me develop the practice, that helped me interpret what people were saying that I could do or what the attitude I need to have and so forth. It's one thing to hear it, but it's another thing to be in a supportive group with a facilitator and a workbook or whatever the case may be, to sort of practice those things and really absorb them and make them part of your new way of being with that person. One of the first course I took actually was with our own Dr. Rhodes, called Adapt, which was wonderful. And I did the Powerful Tools for Caregivers. Those are both in-person things, but there are several online. So my question to you is, do you have 1 or 2 or 3 recommendations that could be given to caregivers for a series of courses where they can learn how to change their attitudes and improve
You're
their
talking about
perspectives
formal
and skills?
caregivers more than family?
Informal, family members, yeah.
Okay. Well, one of the things I saw, Lynn Cordy just went off the call. She's with DSHS. DSHS has now for almost 15 years been training Area Agency on Aging case managers to offer a program called STAR-C for STAR caregivers, which was developed at University of Washington. I was involved in that development with Linda Terry and Rebecca Logston for years. And I still consult with the state AAA case managers. And for people who are within the AAA system and can access that, now there are some, I think, income restrictions on that, but that's a really fabulous program. Many people have come to STAR-C as a referral from Powerful Tools because the leader of the Powerful Tools class felt like they needed more individualized, personalized attention. And STAR-C is a program where the case manager meets with someone 6 times over approximately 6 to 8 weeks and gives them very practical skills training in communication and realistic expectations and kind of ABC behavior management, helping engage persons with cognitive impairment in meaningful, pleasant activities, taking, respite, self-care issues for the caregiver. So it's a very excellent program. Is it possible to get the link here? Gosh, I wish Lynn wasn't on, hadn't left. We can certainly get you some contact information for the StarSea program. So that would be one place. StarSea was also piloted at Kaiser. I don't know if they've rolled it out as an actual program or not, but they did a randomized trial with it. So other than that, there's nothing that I personally am recommending. You know, everybody has their own favorite speakers that they go to hear when they go to the Alzheimer's Association conferences that, but I don't have particular, I don't have particular courses and things that I send my caregivers to.
I think I just found the link for StarSea. I found a link. I'm gonna put that in the chat there. And we will certainly send that out with the post-session materials too. We'll make sure we got the right one. But yeah, I was gonna ask a similar question in terms of, books or other, favorite, I know there's some really nice kind of like vignette videos around specific behaviors or other things. I didn't know anything else on your resource list that you would offer to folks.
Let me think about that and see what I can get back to you. I certainly, I should have prepared something like that in anticipation of a question, but I didn't. So I do have resources that I send caregivers to, both in terms of reading and videos and, miscellaneous this and that, specific to whatever of topics that are pertinent for them. But
The other programs that come to mind too, there's the Savvy Caregiver, and then there's the Savvy Caregiver for Indian Country. Those are both for from our tribal communities. Those are both excellent resources too, but it's hard to tell who's actually offering those. You can find the manuals, but you can't always find the programs.
right, that's what's so great about StarSea is in Washington State. Like I said, we have been, we've had dozens and dozens of people have been trained up in this program, and it's been offered to hundreds and hundreds of dyads across Washington State. And it's a time-intensive program in a sense, unlike a group where everybody's coming together. You got one-on-one time spent with people who are trained in this intervention, working with caregivers. And so they're able to completely individualize the problem solving and the communication and all of the strategies that caregivers need help with. They get personalized attention, actually figuring things out, which is pretty wonderful.
Absolutely. And Karen Clay, I know you do a lot of work in this area too. I don't know if you've got things you would recommend or.
Yeah, I was just about to ask too. I would say that I am constantly on the hunt for good like vignettes, especially for people that are kind of more early stage in their resources, because I feel so many of the videos are for people who are much more late stage, that feature folks that are much older. And so our folks that are really struggling in the earlier stages or moderate stages, they're like, oh, that isn't relevant, even though I do think that the principles are helpful. But I'm very much still in the hunt for that, for those resources. I feel like too, like so many resources are written for like the masses. And so there aren't as many resources for people that have a pretty sophisticated like understanding about behavior that actually feels like it's going to resonate. So I'm going to keep looking. I appreciate if anyone else finds those to share them, because I still haven't found that. And Susan, I just want to say, like, this has been a really helpful and kind of like really, really soothing presentation too. I feel like I've just got, a number of really beautiful nuggets to share with the families that I'm working with. So I'm really, I took lots of notes too to refer back to. But I also, I also really appreciated that comment that you had about, we do focus a lot on using validation and redirection. And then I think you mentioned that if you're doing that too early in the course, there's that risk of causing people to feel dismissed, which I do see. I do need to think about that more. I feel like that was one of those like really nice moments for me to think about how to how to work with those situations more effectively. I don't know if you have any additional words of wisdom related to that. Um,
Well, thank you very much. I appreciate your comments. I don't think I have any additional words, except it's just something that I've become more aware of over
Mhm.
my own practice experience increasing over the years.
Mhm.
I think for many of us, when we got into this field, we didn't see so many of these early people, right? Dementia's being diagnosed much earlier and earlier now. People have much more awareness of, you get folks with an MCI diagnosis that maybe turns into an early Alzheimer's diagnosis over the course of a year or so. And they already have a picture in their mind of what this means because there's so much popular press. And part of what we're doing, I think, is, let me see if I can articulate this, is I'm trying to get people to understand this point that we cannot predict what any person's course is going to be like. So we need to operate under the assumption that how you are today is how you're going to be tomorrow. And we need to build quality of life in right now. And if you've got things on your bucket list that you haven't taken care of, well, maybe you should start taking care of them. But to set aside the mental picture of this is what I'm going to be like because my grandpa was, and focus more on building on the strengths of your relationship together, of yourself, your strengths as each individual person, the ways that you have effectively coped and managed with things your whole life. How can those be incorporated into dealing with this situation? Trying to build upon strengths and present moment awareness with a focus of there's life to be lived. This is more, you are more than your diagnosis. And I think when you're kind of approaching things from that perspective, then I, anyway, am much less likely to fall into sort of the same trap our clients do. Where I'm thinking down the line, oh, well, this person has X symptoms, so that means this is what's going to happen. That doesn't mean this is what's going to happen. Maybe that'll happen, maybe it won't. Let's look at this individual situation and the psychosocial and environmental and historical factors that are contributing to this particular behavior in this person at this moment, and how can that be worked with, and try to not clump people together like everybody's a certain thing when they have a Lewy body dementia, or whatever. So I don't know if that makes sense, but it's really, we came up, I think, in our training world, many of us who are of my age anyway, when it was only people with more severe disease that we were dealing with, and we got this mindset of how to deal with them. And now it's a different world, for the better, I think, for sure.
Yeah, I agree. Like dramatic shift in the past 2 years about the stage in which I see people in a dementia clinic too, but it's amazing.
Rapidly evolving state.
Yeah.
But thank you again, Dr. McCurry, for
Oh, sure.
time and your wisdom and perspective. And I think we've all will take something away that will inform our practice. I know I will. So let's see, just a couple of closing notes. I know we're right at time. I'm not going to reshare slides, but I will let you know that we do have a bonus echo session next Friday, March 7th, 12:15 to 1:15. Same link, we'll send out the info. You're welcome to join. And then after that, we've got kind of a not carryover, but a complimentary presentation on the 14th from our own Karen Hayes around aggressive behavior, violence, and dementia, caregiver and law enforcement perspectives. Looking forward to that. The information for CME, if you are a UW affiliate, is in the chat. And otherwise, also in the chat is the link to the very brief survey. Really do value your feedback, and we will look forward to seeing you at a future session. Hope you all stay well and enjoy spring.
Okay. Thank you, everyone. Take care.
Thank you.